So people often ask me, how do you know that the program worked? How have you judged success? We come back to the fact that the principal reason the program was established was to be able to measure the scale of acute kidney injury across the country. And we can do that now. Using the laboratories and their hard work, we now have the ability to create this master patient index, and from that we can deliver a register. But why is measurement so important? Well, it's both, if you like, the judge of the situation. It tells us how well we're doing, but more importantly, it tells us how to improve. And that's why the measurement piece here is so important. Because if you go and look at all of the journals and so on that have talked about acute kidney injury, it always uses that word estimate in there. Now we have an ability to be certain about what's going on, and from that certainty of what's going on, we can then come up with a plan about improvement. And I look on this program, successful as it is, has been actually the first stage of a very big journey to really embedding improvement in the care of people we look after.
I think the measurement workstream has achieved quite a bit of success in the Think Kidneys program over the last 2.5 to 3 years. Lot of trust have been submitting data to UK Renal Registry with regards to acute kidney injury, and I think this is one of a kind of a program which no other country has, with a uniform AKI algorithm and all the hospitals submitting data to UK Renal Registry to calculate the incidence of acute kidney injury and basic demographic profile of patients who suffer from acute kidney injury. There is obviously a lot more to be done, and a linkage with NHS Digital in the future will give us much more information which will help us to tackle acute kidney injury in England.
The idea with the Master Patient Index is that you collect the minimum amount of information about the cases where acute kidney injury has happened, and then you connect that to other healthcare data that exists already in the system, so that you aren't collecting data again and again and again for multiple reasons. And so when somebody has a case of acute kidney injury and it's identified in a laboratory, they create a flag, and then that patient's information is sent to the registry for us then to be able to link to hospital episode data, acute care data like intensive care, and other national data. And so it's an efficient way of building from a very central core piece of information. We can actually build up the whole picture about the experience that the patient has from their GP to when they go into hospital, to if they go to intensive care, to when they go back home, do they get readmitted to hospital. You can build up the whole picture just by connecting that very core bit of information about the patient into other databases.
The Master Patient Index was, for me, one of the real successes of the programme. Basically, because unless we have the underpinnings of measurement, we'll never know about the development of the disease, other areas that may cause acute kidney injury, whether we've actually improved our performance against the baselines that we're beginning to be able to measure. I think some of the key elements were the fact that we could work with NHS England and other organisations to actually produce something like the Patient Safety Alert that mandated first the installation of the algorithm, but secondly the sending of data to the UK Renal Registry. Now, some might say that it's taken a long time for some of that data to come in. We're now up to 70-80% of laboratories beginning to send us data, and we're beginning to be able to translate that into the numbers of patients that have acute kidney injury by things like CCG and the survival. Now, that's unique in the world, and we're going to be able to build on that more and more as this database expands. We can link to other data sets, so we can look at the hidden costs of things like acute kidney injury, so we can link to other databases, look at diabetes and the relationship between being a diabetic and having acute kidney injury, the relationship between acute kidney injury and chronic kidney disease. There are a whole series of questions that can start easily tripping off once you've got that baseline and that solid database as to the numbers of patients with acute kidney injury and their survival. The most challenging part, as always when you're trying to implement these things, is the NHS, because of the financial issues that it faces, struggles in terms of keeping its systems up to date, its IT systems in particular. So you find a lot of laboratories that had IT systems that were archaic and couldn't actually produce the data that we needed. But having the strength of a national patient safety alert, and then even moving further forward, so it's going to be included in accreditation, means that naturally you're going to get laboratories eventually getting the funding to update these things or changing their systems. So you consider the UK Renal Registry to get national coverage took a long period of time, 15 years or so. Yet within a year or two we're up to 80% coverage, and I would expect within another year we'll get 100% coverage within NHS England. We can work with NHS Wales, we're already having discussions to include their data in, and then NHS Scotland and Northern Ireland, so we'll have a UK-wide coverage understanding acute kidney injury.
So what can measurement do? How can measuring things achieve anything? I think that the main impact of measuring is the understanding it gives everybody involved in AKI, both people who use the NHS and those who deliver healthcare, an understanding of what we're achieving and what more we need to do. I think we always need to improve, we always need to go further with the quality of care that we deliver and understand more about the experience of acute illness as we're trying to make people better. And measuring allows us a window onto understanding what it is that we get when we deliver healthcare, what it is that results from the coordinated efforts that people have across the acute care continuum. And I'm really excited to find out what the results of the first measure analysis will be from the Master Patient Index, because we generally don't know what's the variation in healthcare. What happens to people who have AKI in Portsmouth compared with Preston? For CCGs in London, is it different if you're in Tower Hamlets and if you're in Chelsea and Westminster? What should people be expecting? And for patients to be able to find out from publicly available data and how we clearly can communicate what's happening, people know what's going on in their area, and that can lead to, if people think actually this isn't right for us, it needs to be better, then this allows the public an opportunity to understand how it is that their services need to improve. It allows the clinicians who offer care a chance to understand actually we do need to be better, and this is the particular element of the AKI care that needs to get better. And to be able to provide that in a clear way and push it out to the NHS and to people, I think is an incredible tool actually that the NHS England will have as a result of this work stream.
So then once you're collecting the data routinely, you can use that data to see whether introducing some new practice or some new way of providing care makes things safer for patients. So you're collecting the data routinely, and you can test whether if I introduce in a series of GP practices something that maybe prompts people to look at medicines when somebody's unwell, you can test whether that prompt actually leads to a reduction in cases of acute kidney injury and a reduction in harm from acute kidney injury. So the data is there, it's been collected, we're using it for quality assurance, but then just by having it in the background, you can test whether introducing something at a random time leads to an improvement, which is due to that intervention and not due to random changes over time due to a whole range of other things. And that gives you the evidence that you need to say, this intervention worked, and therefore it was worth us investing some time or some money into delivering that intervention in healthcare. Because if it doesn't work, we should not be doing it, and we should be focusing our efforts in other areas which may work and may lead to benefits for patients.